I'm Lori Berard, and I'm here with Dr. Pratik Choudhary, who is from the King's College Hospital in London, UK. And we've been talking about diabetes and devices because it's very exciting. So we've talked about continuous glucose monitoring and insulin pumps. Let's talk about when these people come in through the ER. What would bring them into an emergency room, and what does that admitting person in the ER need to think about?
Yeah. So I guess, the reason someone comes into the ER is just the same as anybody else, right? And I guess in my mind, I'd like to break that up into a couple of different ways. So I think there's a small group of people who come in because their devices malfunction. And we talked about this a little bit when we talked about pumps, but when someone's on an insulin pump, for example, it's infusing insulin all the time. And if that cannula, which is infusing insulin, gets kinked or blocked, or if they have a pump malfunction, then those people can go into diabetic ketoacidosis with high glucose levels and maybe some ketones.
How long does that take?
So I guess before you get significant ketones, that pump has been blocked off for 6 to 10 hours, actually, before you run into trouble. But the typical scenario is someone's got a high reading at bedtime, and they think it's just because they misjudged their meal. They take an extra correction, but because the cannula's kinked, they didn't get it, and they go to bed. And then by the time 8 hours later, when they've woken up, they've got really high sugars and ketones and feeling really unwell. They might have started vomiting, and that's the sort of scenario when people come in.
So it sounds like what can happen is that people think that they're doing the right thing.
Yeah.
And in a situation like that, even if they had a device that had a high or low alarm in it, they might have shut their alarm off because we know there's some alarm fatigue. So the device is not waking them up, and they're waking up thinking that they've been getting insulin all night. So it's not just because they're ignoring what the device is saying to them.
Yeah, and generally speaking, that's the case. Or sometimes if you have people who don't measure their glucose that much, then people who are measuring their glucose very infrequently, and they've got the pump, it's giving the insulin. Our younger patients often tend to be in that sort of category sometimes. And they can be ones at risk, actually, if they think the pump's giving them insulin, but it's blocked off and it's not. And a common thing that we see this also is, those cannulas, those infusion sets need to be changed every 3 days, ideally. And if you leave it in for 4 or 5 days, because of course the pump has 300 units, and that might actually last someone a whole week.
Right.
And so if you get to day 6 and day 7, you're waiting for it to run out, that's another risk factor where we see this happening.
Okay.
And actually for the ER physician, it's a pretty straightforward thing. Patients high glucose, got ketones, they would manage that just as they manage any person with type 1 diabetes who's coming in with high glucose and ketones. But the key thing to remember here is get the person to, if they're on a pump, get them to change their set, put a new one in, and make sure that they're getting the insulin that way.
Is there any one particular hint that you could give to an ER physician, for example, to say this would be a key that it's pump failure? Or sorry, not pump failure, but cannula blockage. Is there any sort of
I'd probably say if the person says I've been doing lots of corrections and the sugar hasn't been coming down, or it's someone who's not changed their set very often, and you ask them when did you last change the set, I think those are the two key things.
So doing the action to correct, no results.
No result.
Maybe it's been a week since I've changed my set. Okay. Pump failure? Any hints on how they could say that the pump, battery, what would that look like?
So that's kind of quite rare in a sense for that to be an issue. The pump, if there's a mechanism failure, the pumps generally generate an alarm and kind of beep up and say there's a problem. And most people on pumps would then know to contact the technical support. All pump companies have a 24/7 technical support, and they'd be given advice. Now, in that scenario, if the pump's failed and that person doesn't have insulin around, which they would generally been advised to, but they might not have, then of course they just need some insulin in that scenario.
So that's a great example, because that's the person they know their pump's not working, but they actually don't know what to do. Or they don't have something to deliver their insulin with, or they're not sure how to actually manage on their own, and it's in the middle of the night and they're not calling their diabetes doc, they're coming to the ER.
Or it's like when you get a call when the patient's on a transatlantic cruise and their pump fails and they're 4 days from New York and you have to find a way to get them insulin. So
there you go.
Great. That's my best story on that.
What other reasons would they come in acutely to an ER?
So of course, a person with type 1 diabetes, if whatever their way of insulin, can just be unwell, right? And they can get, even if they're doing all the right things, they can have severe hypos or diabetic ketoacidosis, or they can just have something else. They could be involved in a road accident, they can have a pneumonia, they can have anything that the person comes into hospital with. And at that point, all we need to clock is that they're on a pump, and what their way of insulin delivery is. And I guess the key decision there for the ER physician is how unwell is that person, and are they in a position to manage their pump or not? And if they're really so unwell that maybe their conscious level is affected, or maybe they are just not quite there to do all the work that a pump does, at that point I guess we have to the clinician has to make a call about whether you leave them on the pump or whether you take control of the diabetes until they get better.
And so thinking about an acute setting and they come in on the pump is of course delivering insulin into the subcutaneous space. So the absorption is as we know it is, you know, from the time that the bolus is given, 15 minutes, they typically start to see some action. The bolus is gone, you know, 3 to 4 hours. But there might be situations when someone comes into the ER that subcutaneous delivery might be too slow, and they might want to stop the pump and move them to intravenous type of delivery, or...
So generally, as a rule of thumb, a good rule of thumb would be that if your patient is not well enough to self-manage their diabetes, then your best bet, your safest bet, everyone knows how a sliding scale or intravenous insulin works, and if you're not sure, take the pump, disconnect the pump from the skin. So make sure, what you don't want to do is do dual delivery.
Right. Yes, absolutely, yeah.
Because that can be quite difficult. And then you're on your IV, and then kind of most clinicians know what they're doing with intravenous insulin, and they can run that. And so if in doubt, I think that's always your fallback. If your patient is unwell, but able to manage the pump, and they seem to be on top of their glucose levels, I think that's a much better experience for the patient if they're allowed to do that, and they can stay in control of their glucose levels, because they will generally know what to do.
So I think what we've talked about in terms of the acute reasons to come into an ER is it could be definitively related to the device and failure. And then the second reason is something else has gone on that's made their blood sugars either go very high or very low. The pump is not the culprit in this particular scenario. There's something else going on. So you would have made sure the pump is working. Then you're looking at what else is causing it, starting to treat that. And if the person can manage their diabetes through their pump, treat whatever else is going on, work together, let them use their insulin to give the boluses they need. And if at all in doubt, you can go to whatever works for you in the past. You're comfortable with intravenous glucose or sliding scales, and there's nothing wrong with that. Just remember that when the patient's well enough, to give them back control of their diabetes.
And I think in that scenario, of course, we talked about this a bit about continuous glucose monitoring. Some of these patients may have a monitor, and I think it's quite useful to use that information in your decision making. And I think the other thing to be aware of is, of course, either the illness itself or the treatments we give to treat the illness. So steroids is a classic example of that, can have huge impact on glucose. And if your sugar levels are high because you're given a steroid, it doesn't mean the pump isn't working. It just means you need to work out how much extra insulin to give to get on top of that. And as a rule of thumb, I would say if the person is eating and drinking, they should be well enough to manage their own diabetes and just increase the doses that you give. And that eating and drinking, if they're not eating and drinking, then that's generally a good marker that you might need to consider what you're doing. And one of the advantages of a intravenous insulin is we often give dextrose and insulin together, and so they are safer in that sense sometimes.
But it would be safe to say that when we have an individual with a continuous glucose monitoring system, that it really actually can make the management for the ER physician much easier, because there's so much information that they can see instantaneously the effect of their
what's
therapies.
Happening. And you have those alarms to help guide you that can, and we talked a little bit about the accuracy of continuous glucose monitoring when people were unwell, and on the whole, the evidence says that they're good enough for you to make sensible treatment decisions. Clinical decisions, but if in doubt, you can use those to guide the timing of your finger prick. So if you've got a sensor that's showing that you're dropping rapidly and you might be close to hypo, you might want to confirm that with a finger prick and take appropriate action, and rather than wait till the glucose is too low.
So lots of opportunities to embrace technology in the ER.